So I'm Clive Page, I'm President-elect of the Society, and it's my pleasure to introduce the last speaker this afternoon, who's our Gaddum International Lecturer, Professor Carlo Patrono. Sadly, Carlo is not able to join us in person because of the COVID restrictions, but he is going to be giving his lecture live. He's well known, of course, to many of us in the Society. He spent some time actually here in the UK. But Carlo actually trained in medicine at the Catholic University School of Medicine in Rome, where he's now the Professor of Pharmacology. He's also a professor at the University of Pennsylvania. And I think Carlo is well known to all of us in the platelet biology field as for his seminal work on explaining how aspirin should be optimally used as an antithrombotic. He's also done a lot of work with cyclooxygenase 2 inhibitors and evaluating the cardiovascular effects in different clinical settings, as we touched on that a little bit today. He's a member of the Scientific Advisory Board of the William Harvey Research Institute here in London, and also the International Aspirin Foundation. And I can't think of anybody, Carlo, more appropriate to give the Gaddum International Lecture than you. And he's going to talk to us about a 50-year journey from his own perspective in aspirin research. So, Carlo,
thank you.
It's a pleasure to have you.
Thank you very much, Clive, for this very kind introduction. And please let me thank the British Pharmacological Society and its president, Sir Muir, for the privilege of giving this prestigious lecture on the occasion of the Society's 90th anniversary. I feel deeply honored. And giving this presentation also allows me to pay tribute to two pioneers in physiological and pharmacological investigation, Sir John Gaddum and Professor Ulf von Euler. Exactly 19 years ago, in 1931, they published a joint paper in the Journal of Physiology describing, for the first time, substance P in certain tissue extracts. And 5 years later, Ulf von Euler published another paper in the Journal of Physiology. And it's interesting to read his words during an investigation of various organ extracts for the purpose of finding the distribution of substance P. He made the observation of the existence of other vasoactive substances, which he named prostaglandin and vesiglandin. And this seminal observation is at the heart of this personal journey in aspirin research. So this lecture is also aimed. I'm hearing an echo. I don't know if my voice is getting fine. So this lecture is also aimed at illustrating an unusual paradigm of drug development that was largely supported by public funding and based on discovering how aspirin works in inhibiting platelet function, developing mechanism-based biomarkers to investigate the clinical pharmacology of platelet inhibition, and designing adequately sized randomized clinical trials to evaluate the efficacy and safety of low-dose aspirin for the prevention of atherothrombosis. My field of investigation was in this second step, and I was fortunate enough to be preceded by the seminal discoveries of a few people who discovered how aspirin works in inhibiting platelet function, and to be followed by an army of clinical investigators who were responsible for the clinical trials to assess efficacy and safety of low-dose aspirin. As I will show you, I eventually moved back to further mechanistic understanding and as well as forward to new clinical trials. And talking about mechanism of action, this is Sir John Vane, who was mentioned a few times during this meeting, and the original brilliant cascade superfusion bioassay technique that allowed him to characterize several unknown prostanoids. So exactly 50 years ago, during the summer of 1971, 3 papers appeared in the same issue of Nature and New Biology describing inhibition of prostaglandin synthesis as a mechanism of action for aspirin-like drugs. It's interesting to note that there was a paper by J.B. Smith and A.L. Willis where graduate students in the same department of pharmacology working with John Vane and Gustav Born, respectively, who described that aspirin selectively inhibits prostaglandin production in human platelets. However, if you read the conclusion of their paper, they really talk about the clinical effectiveness of aspirin and indomethacin as anti-inflammatory agents. And the reason they could not establish a link between inhibition of prostaglandin production and inhibition of platelet function is that the only known prostaglandins at the time, that is prostaglandin E2 and prostaglandin F2 alpha, have no major impact on platelet function. And we had to wait a few years until May 26, 1975, when this young biomedical chemist, Bank Samuelson, walked into Palazzo dei Congressi in Florence to the International Prostaglandin Conference, where he announced for the first time the discovery of thromboxanes, a new group of biologically active compounds derived from prostaglandin endoperoxides. So what Bank and Matt Sandberg discovered was initially the existence of 2 unstable intermediates in prostaglandin synthesis called the prostaglandin endoperoxides, prostaglandin G2 and H2, that are the products of the cyclooxygenase and peroxidase activities of PGH synthase, respectively. And then the conversion of these unstable intermediate into a biologically active and chemically unstable derivative, thromboxane A2, which is responsible for inducing platelet aggregation and is rapidly hydrolyzed non-enzymatically into a chemically stable derivative thromboxane B2. So this discovery allowed for the first time to establish a mechanistic link between inhibition of PGH synthase and inhibition of platelet aggregation by aspirin. Today, we know that the interaction of thromboxane A2 with its TP receptor is one of 3 distinct mechanisms of platelet activation, leading eventually to the conformational change in the glycoprotein 2B3A that acts as the fibrinogen receptor. And evidence has accumulated for an important role of platelet thromboxane production in atherothrombosis. The third person I'd like to mention in this first part of the story is Dr. Philip Majerus, a brilliant hematologist working at Washington University in St. Louis in the United States. What Philip Majerus, together with Jerry Roth and Nancy Stanford, described was the acetylation of prostaglandin synthase by aspirin. And so they described using labeled aspirin, the acetylation of a microsomal protein, molecular weight 85,000, by aspirin correlates with a drug's inhibitory effect on prostaglandin synthase. So about 75 years after the marketing of acetyl salicylic acid as aspirin, we knew how aspirin works by converting what we now call COX-1, cyclooxygenase 1, into acetylated COX-1. And this leads to permanent loss of the cyclooxygenase activity of the enzyme responsible for the conversion of arachidonic acid into prostaglandin G2. Over the next 20 years, we had the cloning of the enzyme, site-directed mutagenesis, and X-ray crystallography, which allows us to understand the molecular details of how the enzyme is permanently inactivated by selective acetylation of a single serine residue within the so-called cyclooxygenase channel that is serine at position 529 in the human enzyme. So back to my personal life, I trained between 1969 and 1971 with Professor Solomon Burson, a brilliant clinical endocrinologist, and Professor Rosalind Yalow, a innovative nuclear physicist. They joined their markedly different expertise and invented a brilliant new technique for measuring all kinds of substances, beginning with insulin, the radioimmunoassay. Rosa and Yalow went on to get the Nobel Prize for this discovery in 1977. Unfortunately, Solomon Burson had died earlier for a myocardial infarction. So while working in their lab, I developed an interest in prostaglandins and proposed working on developing a radioimmunoassay for prostaglandin F2 alpha. And by the end of 1971, when I returned to Italy, to the Catholic University in Rome, I had developed a specific radioimmunoassay for prostaglandin F2 alpha based on the same technique, hapten conjugation with albumin, that had been used successfully to develop radioimmunoassay for steroid hormones. It took me about 10 years to build a small but gender-balanced group of young researchers whom I trained as clinical pharmacologists. And I'd like to mention in particular Paola Patrignani and Giovanni Ciabattoni, who played a key role in the aspirin studies I'm going to describe to you. So at the time, the way in which we used to measure platelet function was through the brilliant method described by another pharmacologist, a member of this society, Gustav Born, who published a pivotal paper in Nature in 1962 using light transmittance to detect the biological signal evoked by ADP added to a platelet-rich plasma to induce platelet aggregation. By passing light through a platelet-rich plasma suspension, you would get clearing of this plasma and therefore increased light transmittance. Perhaps not surprisingly, given that Gustav was the son of Max Born, a Nobel laureate in physics. We decided to take a different approach to measure the effect of aspirin on platelet function by exploiting the generation of endogenous thrombin that occurs during whole blood clotting and the triggering effect of thrombin on phospholipase to release arachidonic acid, which would then be converted by PGH synthase and thromboxane synthase to form large amounts of thromboxane A2, which would be hydrolyzed non-enzymatically to thromboxane B2. So essentially, we replace this electrical signal with the an immunological signal provided by the immunoreactivity of thromboxane B2 recognized by a highly specific antibody. And we described early evidence for the effects of low-dose aspirin on this enzymatic pathway leading to the formation of thromboxane B2 back in 1980. Now, what we were faced with at the time was the so-called Aspirin Dilemma, that is, aspirin having an effect on thromboxane A2 produced in platelets and prostacyclin produced by the vessel wall. And these two unstable prostanoids have clearly opposing effects on platelet aggregation and vascular function. Prostacyclin was already mentioned during the presentation of Peter Barnes this afternoon as an endogenous antiplatelet agent. So ideally, you would want to find ways to inhibit platelet thromboxane production while leaving vascular prostacyclin production substantially intact. In 1982, we published this paper in the Journal of Clinical Investigation entitled Selective Cumulative Inhibition of Platelet Thromboxane Production by Low-Dose Aspirin in Healthy Subjects. And this slide taken from this paper illustrates the log linear relationship between the oral aspirin dose given to this number of healthy volunteers and the percentage inhibition of platelet thromboxane production shown on this axis. These were the effects of single oral doses of aspirin within a range between 5 and 100 milligram. 100 milligram given as a single oral dose causing virtually complete suppression of platelet thromboxane production. Now, because of the irreversible nature of platelet COX-1 inactivation, we were interested in exploring the effects of repeated daily dosing with doses roughly corresponding to the ID50. And so we tested the effects of 30 milligram daily given for 1 month to a few healthy subjects. And this slide depicts the platelet thromboxane production as percentage of control. So this is before aspirin. And as you can see, after the first dose, you get some 50% inhibition. And by the end of the week, you get virtually complete suppression of platelet thromboxane production, which remains substantially unaltered throughout the 1 month dosing period. And upon discontinuing aspirin, we saw time-dependent recovery of the capacity of platelets to produce thromboxane, the rate of which was consistent with the platelet turnover. In the same study, we also measured the urinary excretion of 6-keto-PGF1 alpha, the corresponding non-enzymatic hydrolysis product of prostacyclin, and found no measurable change, no statistically significant change in the urinary excretion of this hydrolysis product. Today, we know that serum thromboxane B2 is exclusively the product of platelet COX-1 activity, while this is largely the product of COX-2 activity constitutively expressed in the human kidney, perhaps providing the first example of COX isozyme selective inhibition in man. So based on these findings, we had to revisit the dose-response relationship for inhibition of thromboxane production by aspirin. And while this is the dose-response curve after single dosing, upon repeated daily dosing, you see a shift in the dose-response curve by a factor of 8. So the ID50 goes from 26 milligram to about 3 milligram daily. And this corresponds roughly to the fractional daily platelet turnover, suggesting that upon reaching steady state inhibition, what is necessary and sufficient is a fraction of the full dose acetylating the molecules of the COX-1 enzyme present in the newly released platelets, which within a 24-hour interval are between 10 and 12%. And these findings allowed us to predict that any antithrombotic effect of the drug related to this particular mechanism of action would show saturability of the effect at low doses, even lower than 100 milligram. This is Gareth Fitzgerald. He was already mentioned by Peter Barnes, professor of pharmacology at University of Pennsylvania, and a key person, a key figure in this aspirin story. I met Gareth some 40 years ago at one of these winter prostaglandin conferences. We were competing with each other at the time, but we became friends and have established a personal and professional relationship, which is still very vivid. And Gareth took a different approach to measuring the effects of aspirin on prostacyclin and thromboxane biosynthesis, that is using the measurement of the urinary excretion of major enzymatic metabolites of these prostanoids. And he came up with similar findings to ours, and he also described relative selectivity of low-dose aspirin in fully inhibiting platelet thromboxane production, while at least in part sparing vascular prostacyclin production. Now, this provided the pharmacological basis for testing the clinical efficacy and safety of low-dose aspirin. The key persons in providing the first solid evidence for the efficacy and safety of low-dose aspirin are two brilliant epidemiologists working at University of Oxford, Sir Richard Peto and Sir Rory Collins, and the late Professor Peter Slight, a brilliant clinical cardiologist. Together, they designed and implemented in just over 3 years one of the most important trials in modern cardiology, the so-called ISIS-2, which stands for International Study of Infarct Survival 2. And reading their words, based on our pharmacodynamic findings, they say, although 40 milligram per day will eventually achieve virtually complete cyclooxygenase inhibition, larger doses such as the 160 milligram dose used in ISIS-2 are needed for rapid effect on the first day of treatment. And this was because they intended to recruit patients with an acute myocardial infarction within the first 24 hours after the onset of symptoms. So this is a trial that recruited over 17,000 cases of suspected acute myocardial infarction and tested two different strategies to improve survival, short-term survival. That is intravenous streptokinase, a thrombolytic agent, and oral aspirin, an antiplatelet agent, both or neither. This panel describes the effects of streptokinase versus a placebo infusion on vascular mortality at 5 weeks, which was the primary endpoint of the trial. Streptokinase produced a 25% relative risk reduction in vascular mortality. Aspirin, 160 milligram once daily, reduced vascular mortality by a similar degree by 23%. Again, decrease in mortality from about 12% down to just above 9%. And this panel depicts the effects of the combination of the two agents versus both placebos. And the two agents together produced over 40% reduction in vascular mortality, consistent with this being an additive effect of two pharmacological intervention acting on different mechanisms of coronary atherothrombosis. So this pivotal trial established three important facts. The first is coronary thrombosis is a dynamic process. Second, aspirin is a life-saving drug. And thirdly, antiplatelet therapy and coronary reperfusion, coronary revascularization are two equally important pillars in the acute management of myocardial infarction. A few years later, Lars Valentin in Sweden reported the results of the RISK trial, a trial of an even lower dose of aspirin, 75 milligram given once daily, to roughly 800 men with non-SDE acute coronary syndromes, and over 1 year of treatment. So this was a much longer duration of treatment than in ISIS-2. They saw a 50% reduction in the probability of death or myocardial infarction, with an extremely low number needed to treat to prevent one major vascular event of only 10 patients. Following this important trial, other trials were published using similar low doses of aspirin. And this slide depicts Professor Lars Valentin, Professor Tom Mead, Professor Jan van Hein, and Professor Bo Norving, who were largely responsible for this pivotal trial of low-dose aspirin, and their fundamental contribution were recognized by the International Aspirin Foundation with the 2020 Senior Science Award. So this slide describes an incomplete list of vascular disorders in which aspirin has been tested against placebo and shown effective. And this column describes the minimum effective daily dose of aspirin shown effective in each of these clinical settings, which ranges anywhere between 50 and 160 milligram, with the 160 milligram dose having been used in the acute ischemic syndromes, both in the coronary and in acute ischemic stroke. Now, having established that such low doses are effective, many physicians around the world, in particular in North America, have been asking the question, and they have kept asking the question until very recently: are higher doses more effective because of dose-dependent pleiotropic effects of aspirin? And the key person in answering this question is Professor Colin Bagent, an epidemiologist in the same department of Rory Collins and Richard Peto at the University of Oxford. Colin has established and coordinated the so-called anti-thrombotic trialist collaboration of all the investigators who did aspirin trials in high-risk patients, largely secondary prevention trials or trials in the acute setting. And this slide shows the relative risk reduction of major vascular events, fatal and non-fatal coronary and cerebrovascular events, in trials using the lowest doses between 75 and 150 milligram. Those trials using intermediate doses of aspirin, and those trials using the highest doses of aspirin up to 20-fold higher than 75 milligram. And as you can see, there is absolutely no evidence of any dose-dependent effect potentially attributable to these dose-dependent pleiotropic effects of aspirin. If anything, there seems to be an attenuation of the antithrombotic protection afforded by aspirin as a function of increasing doses. Mind you, these are indirect comparisons, but there are at least 2 trials in over 40,000 patients with acute or chronic coronary syndromes that have established the similar beneficial effects of low doses and intermediate doses of aspirin. Now, of course, there is a price to pay for this benefit because the same mechanism that I described to you, that is thromboxane-dependent platelet activation, plays an important role in the primary hemostasis, in the hemostatic plug formation after an acute injury. And so this slide depicts the balance between the benefit, that is the number of major vascular events avoided per 1,000 treated per year, versus the excess risk of major bleeding complications caused by aspirin per 1,000 treated per year. And while in those clinical conditions outlined in red, the benefit clearly outweighs any risk of bleeding, in so-called primary prevention, there is a small probability of obtaining a benefit similar to a small probability of causing harm. And I would like to emphasize that this apparently uncertain balance represents a best case scenario because elderly subjects were underrepresented in primary prevention trials, and people with high bleeding risk were excluded from participating. So in order to address the question of what really happens in the general population, I collaborated with a brilliant epidemiologist at the Spanish Center for Pharmacoepidemiology in Madrid, Dr. Luis Garcia Rodriguez. And together we published this paper in the New England Journal of Medicine describing the rate of upper gastrointestinal complications, which are largely bleeding complications. At least 90% of these complications are bleeding, hemorrhagic in nature. And this describes the rate of these complications per 1,000 persons per year as a function of age on the abscissa in increasing decades, and as a function of the severity of prior gastrointestinal history. What you see in black is what happens in the general population not using aspirin. And as you can see, there is a age-dependent increase in these complications. And within each decade, you see an exponential rise of these complications as a function of this history, the severity of the history going from a negative history up to a history of complicated ulcer. Now, aspirin roughly doubles the risk of these complications, and what you now see in red are the corresponding figures for aspirin-treated individuals. And the height of these vertical bars represent the excess of these complications due to aspirin. And you can calculate the number needed to harm at the 2 extremes of this very wide range, that is comparing a very elderly person with a prior complicated ulcer with the number needed to harm is only 17, to a young person less than 50 years old with a negative prior history, where the number needed to harm is roughly 100-fold higher, emphasizing the need for personalized antiplatelet therapy. And this is also illustrated by the fact that you see the same excess of these complications in a very old person with a negative prior history as in a very young person with a prior history of a complicated ulcer. Talking about personalized antiplatelet therapy, the question we ask ourselves several years ago is, does one dosing regimen fit all? And the answer is probably not, because we found that there is substantial inter-individual variability in the rate of recovery of platelet COX-1 activity during the 24-hour dosing interval. perhaps requiring more frequent dosing in patients with accelerated renewal of the drug target. And I'd like to illustrate this concept by discussing with you the case of essential thrombocythemia. And the key person that played a fundamental role in these studies is Bianca Rocca, who is professor of pharmacology at the Catholic University in Rome. So essential thrombocythemia is a myeloproliferative neoplasm characterized by specific bone marrow morphology, characterized by abnormal megakaryopoiesis, and increased risk of thrombohemorrhagic complications. Bianca reported that thromboxane biosynthesis is persistently enhanced in ET patients, essential thrombocythemic patients. And together with Alfredo Dragani, we have found that the rate of thromboxane biosynthesis in aspirin-treated ET patients is consistently higher than in aspirin-treated healthy subjects. And this is illustrated by this slide with individual measurement of serum thromboxane B2 in over 150 such patients, as compared to healthy individual, aspirin-treated healthy individuals. As you can see, some 70% of the ET patients display variably and incompletely inhibited platelet COX-1 activity, as shown on a log scale by measurements of serum thromboxane B2. So if you look at the bone marrow of these patients, you find both COX-1 and COX-2 being expressed in the platelet precursors, the megakaryocytes. If you look at the peripheral platelets, you only find COX-1 being expressed by mature platelets. And the question we were facing is not so much the increased platelet mass, which would be dealt with by increasing the daily dose, the single daily dose of aspirin. But the problem we were facing was the rate at which the platelet target of aspirin was being replaced through abnormal platelet production and accelerated platelet turnover. So using the same approach that I described to you through measurement of serum thromboxane B2, we characterized a time-dependent partial recovery of platelet cyclooxygenase activity in aspirin-treated ET patients as compared to healthy individuals, particularly during the 12 to 24-hour dosing interval. And based on these findings and based on in silico modeling, we reasoned that twice-daily dosing might be able to rescue this abnormal biochemical phenotype. So based on this consideration, we designed a proper phase 2 dose-finding study to explore the effects of 3 aspirin regimens to optimize antiplatelet therapy in essential thrombocythemia. And this is the results of the ARES trial coordinated by Valerio De Stefano, head of hematology at the Catholic University in Rome. This is the design of the first phase of the study, whereby we randomized some 245 ET patients to receive aspirin 100 milligram once daily, twice daily, or 3 times daily. We obtained measurements at visit 2 when they were all on 100 milligram once daily, and at visit 3 at the end of 2 weeks of randomized regimen. And this slide depicts in blue what happened of the ratio between visit 3 and visit 2 serum thromboxane B2 in those who remained on 100 milligram once daily. So they remained essentially around the identity line, ratio 1, while both those randomized to receive aspirin twice daily in yellow and those randomized to receive aspirin 3 times daily in gray showed a 1 to 2 orders of magnitude lower ratios of the visit 3 to visit 2 serum thromboxane B2. Now, based on these findings, we have chosen 100 milligram twice daily as an improved aspirin regimen to be moved forward into a phase 3 trial, which we hope we will be able to set up at the European level. Finally, I would like to briefly review with you what happened during the past 20 years on a completely different side of the story. That is the fact that there are many observational studies, and there were already in 2001 when we published this paper, observational studies establishing an association between regular use of non-steroidal anti-inflammatory drugs, including aspirin, and reduced risk of developing colorectal cancer. And the surprising finding in these observational studies was that there was no apparent dose-response relationship for the potential chemopreventive effect of aspirin. And we reasoned in this paper with Paola Patrignani and Luis Garcia Rodriguez that activated platelets at sites of intestinal mucosal injury, where platelets participate in tissue repair, there might be the release of pro-angiogenic and pro-inflammatory mediators, such as those illustrated on this cartoon, that would act on adjacent nucleated cells, endothelial cells, and stromal cells of the intestinal mucosa to induce COX-2 expression, which would then drive prostaglandin E2 production, which has an effect in stimulating angiogenesis, inhibiting apoptosis, and enhancing cellular proliferation. And if this hypothetical sequence of events was correct, then one would anticipate a similar protective effect by acting upstream with low-dose aspirin, preventing platelet activation, or downstream with traditional NSAIDs or COXIBs, inhibiting COX-2 activity in adjacent nucleated cells of the intestinal mucosa. During the past 20 years, several sources of evidence have been produced in addition to observational case control studies. So 4 randomized placebo-controlled clinical trials have been completed in subjects with sporadic colorectal adenomas. 1 placebo-controlled randomized clinical trial has been completed in the Lynch syndrome with post-trial follow-up. We have seen the report of long-term follow-up of the Women Health Study, a placebo-controlled primary prevention trial of aspirin administered every other day, and interesting work carried out by Peter Rothwell in Oxford on the post-hoc meta-analysis of all the cardiovascular trials of aspirin in over 75,000 participants. Now, I will share with you just number 2 and number 3 because this is evidence coming from prospective placebo-controlled randomized clinical trials that avoid biases inherent to the other studies. So this is a meta-analysis of the 4 adenoma trials in a few thousand patients, roughly 2,700 patients, who were diagnosed a sporadic colorectal adenoma, which was removed, and they were randomized to receive aspirin or placebo, followed for about 3 years, and adenoma recurrence was the primary endpoint. And as you can see, there is roughly a 20% risk reduction in the risk of recurrence of a colorectal adenoma, and roughly a 30% reduction in the risk of recurrence of an advanced lesion. And thinking back of the hypothesis we put forward in the JCI paper of 2001, it's interesting that similar studies have been carried out with rofecoxib and celecoxib. This is the approved trial that led to rofecoxib withdrawal because of the emergence of a cardiovascular toxicity. But it's interesting to note that in terms of relative risk of any colorectal adenoma, the benefit associated with rofecoxib 25 milligram is pretty similar with that produced by aspirin at a dose as low as 81 milligram. consistent with the hypothesis we put forward. And this is the main finding from the CAP2 study in patients with hereditary colorectal cancer, the Lynch syndrome, over 10-year follow-up and registry-based 20-year data. And one interesting feature, which is recurrent in many other observations, is the existence of a time lag of between 8 and 10 years before you start seeing a divergence of the Kaplan-Meier curves describing colorectal cancer development in the aspirin placebo in blue and aspirin-treated patients in red. This is the work of Sir John Byrne at Newcastle University, and this was the basis for NICE to issue a new guideline in the end of January of last year, suggesting to consider daily aspirin to be taken for more than 2 years to reduce the risk of colorectal cancer in people with the Lynch syndrome. Paola Patrignani, who is chair of pharmacology at University of Chieti, has conducted more experimental work in murine models and clinical studies where she showed that aspirin prevents colorectal cancer metastasis by splitting the crosstalk between platelets and tumor cells. That low-dose aspirin may acetylate COX-1 in human colorectal mucosa, though to a lower extent than in platelets, and that platelet-specific deletion of COX-1 ameliorates experimentally induced inflammation in mice, contributing knowledge to a revised scheme whereby we suggest that in addition to acting at an early stage of colorectal carcinogenesis, there is the transition of a normal mucosa to an adenomatous lesion. Aspirin prevents this transition, as shown by the sporadic adenoma trials, but may also have an effect later on, and in particular in preventing the diffusion of metastatic cancer cells and interfering with epithelial mesenchymal transition. Now, these sort of findings provided a rationale for the work of Professor Ruth Langley, Professor of Epidemiology at University College London, who designed and is implementing the largest placebo-controlled randomized clinical trial of aspirin in the adjuvant setting for the treatment of several forms of solid cancer. This is the ADASPIRIN trial, which is essentially 4 parallel phase 3 trials whereby participants undergone primary treatment with curative intent for an early stage common solid tumor, colorectal, breast, gastroesophageal, or prostate, are randomized to receive placebo, aspirin, either 100 or 300 milligram, and are then followed for at least 5 years. And there are roughly 10,000 participants in this trial for a primary outcome of disease-free survival or overall survival. I'm a member of the steering committee of this trial, and together with Ruth, we have designed a platelet activation sub-study within ADASPIRIN, which is funded by a Catalyst grant by Cancer Research UK, led by Jack Cusick here in London, whereby we are measuring the urinary excretion of a major enzymatic metabolite of thromboxane, 11-dehydrothromboxane B2, measured 3 time points at registration, at randomization, after they have undergone a run-in period with 100 milligram of aspirin to test compliance, and then after 3 months of randomized treatment. And we are aiming for 500 aspirin participants across the 4 tumor types, and the data I will show you are unpublished and confidential and are related to 575 baseline samples. So what we found with Ruth and her colleagues is that there is abnormal thromboxane-dependent platelet activation in cancer patients, particularly evident in those with gastrointestinal cancers. Gastroesophageal and colorectal cancer patients have markedly elevated levels of thromboxane-dependent platelet activation as reflected by this urinary thromboxane metabolite as compared to healthy individuals. Now, whether persistent platelet activation contributes to metastasis formation or cancer recurrence, of course, will need to wait the results of the clinical intervention with this, within this trial. And these are the primary outcome data expected between 2025 and 2027. So it looks like I will keep busy for some time. And so the journey continues, and this is thanks to my colleagues in Rome and Chieti, particularly Bianca Rocca and Paola Patrignani, and my collaborators in London, Ruth Langley, Jack Kuzik, and in Oxford, Colin Page and Jane Armitage, as well as the funding from these sources, which is essential. And I thank again the British Pharmacological Society for this very prestigious invitation. I'd like to thank you all for listening to this last presentation of the day, and enjoy the evening. And of course, I'll be more than pleased to answer any questions.
So thank you very much, Carlo, for a fantastic lecture and a run-through of the last 50 years and a lot of the seminal work that you and your colleagues have done with aspirin. And it's, as you say, I'm sure we're going to be busy for a number of years to go going forward. I'm sure there are some questions, Carlo. I realise it's quite late in the evening for you, but are there questions to Carlo from the audience? Whilst I'm thinking about it, Carlo, I mean, on the last point about the metastasis, I mean, there's a lot of literature in the last 10 years, as you know, that platelets are critical to get leukocytes to go across the endothelial wall. Our old concept of chemotaxis to chemokines is probably more complicated in vivo. It involves platelets and leukocytes in the endothelium. And of course, there's a lot of literature about platelets interacting with metastatic tumour cells and using similar adhesion molecules to get out. And I wondered if you've got any work, or you know of any work, that suggests that some of the effects you're seeing here with aspirin are actually reducing that actual recruitment of metastatic cells as opposed to what those cells may be doing themselves.
Yeah, you're absolutely right. There is this a huge amount of work being carried out by several laboratories, and including Paola Patrignani's in Chieti. And we think that platelets may play a protective role in interacting in the blood circulation with circulating metastatic cells. And this interaction, which involves probably several known receptors, works in protecting cancer cells from immunological recognition. And the expectation is that by preventing platelet aggregation to circulating cancer cells, one may facilitate immune recognition of metastatic cells by the immune system. But of course, this is a beautiful theory, and the proof of the pudding is to see what happens in the Aspirin trial.
Any, please.
Thank you. Hello, Professor Patrono. Thank you very much for your talk. I just wanted to ask about platelet activity assays. So you've mentioned several in your talk. The first one, light transmission aggregometry, and then thromboxane, plasma and urine measurements. There are many point-of-care platelet activity assays, such as multiplate, PFA 100, and Verify Now. Do they have a place in clinical practice in order to optimize dose of aspirin?
Well, there have been several trials that have tried to demonstrate the clinical utility of such point-of-care assays, but unfortunately, none has been able to demonstrate the efficacy of these kind of measurements. There is a recent meta-analysis that, putting all the data together, suggests a potential improvement of guided antiplatelet therapy versus conventional antiplatelet therapy, but none of the individual studies really convincingly shows the point. In terms of specifically aspirin, I think the serum thromboxane B2 measurement offers a much higher degree of specificity and sensitivity than any other functional assay, because 99.9% of the signal is completely abolished by low-dose aspirin, while this is not the case for any functional assay in response to exogenously added agents.
Thank you, Carlo. Any other points? Munir.
Carlo, thank you very much for an excellent talk. I just wanted to ask you about aspirin resistance. Do you think that's a true phenomenon, or is it just because the studies haven't really taken into account that people just weren't taking the aspirin and they were then falsely labeled as being resistant?
I think the latter interpretation is the correct one, Munir. I believe that none of the early studies of aspirin resistance really took into serious consideration non-compliance. Also, they were based on single measurements at an arbitrary time point. If you witness aspirin administration and measure thromboxane B2 24 hours after dosing, you will find consistent reduction in serum thromboxane. What may change, as I showed for the extreme paradigm of essential thrombocythemia, is the variable duration of the antiplatelet effect. But there is no true resistance. Everyone, including the essential thrombocythemic patients, show complete response to aspirin. It's only a question of how long does it last as a function of how fast is the rate of renewal of the drug target.
Can I ask another one?
Please.
So you showed a very nice graph of the fact that the number needed to harm decreased as you got older with regard to upper gastrointestinal problems with aspirin and so on. Do you think that the age as a predisposing factor to that is related to increased susceptibility to mucosal injury or reduced ability to be able to repair the mucosal injury, or both?
I like to think that there is impaired capacity for repair mechanisms, but that's only a working hypothesis.
Yes, there's a question right at the back, on the back row. I think it's Jeff Aronson. I can't quite see you if it is Jeff or not.
Thanks, Clive. Thanks, Carlo, for a beautiful presentation of some very elegant clinical studies. I wonder if you have a view on the possible role of aspirin in either treating or investigating the rare thrombotic complications of COVID vaccines.
You know, there is some investigation ongoing into the possibility of aspirin interfering with these complications. The problem is the rarity of the most serious complications, which would make a realistic clinical trial possibly unfeasible. Having said that, aspirin has been used in COVID patients in order to try and reduce 28-day mortality, but according to as yet unpublished results of the recovery trial in Oxford, aspirin was unable to reduce 28-day mortality. There were some smaller benefits, like a shorter duration of hospital stay, a slightly increased percentage of patients being discharged alive at 28 days. And there were the typical beneficial effects of aspirin in preventing myocardial infarction and stroke during this 28 period, but also the increased risk of bleeding, which tended to balance each other.
Carlo, I have one final question for you from one of our online delegates who's asked whether or not the protective effects of aspirin against cancer will be replicated with other antiplatelet therapies, or do you think this is something unique to aspirin?
It's a very interesting question, one that Paola Patrignani has explored in a murine model, and apparently she found that some other antiplatelet agents may have chemopreventive effects, and there is at least one observational study, a population-based observational study done by Luis Garcia Rodriguez on the Spanish population, suggesting that clopidogrel may have a similar protective effect against colorectal cancer as aspirin, which would not be surprising if indeed platelets are the important players in this apparent chemopreventive effect of aspirin.
Thank you, Carlo. So I think, Carlo, with that, again, many, many thanks for your excellent lecture, and we hope we can invite you over here in better times to get your award in person. But you have been listened to by about 200 people online, and there's almost 100 people in the room, Carlo, so you've had a good audience, and it's been really fantastic to have you as our Gaddum International Lecturer this year, and we hope you have a good evening, and thank you very much for joining us from Rome.
Thank you.